All right, good morning. I want to start by welcoming all of you who are joining the QI Power Hour for the very first time. My name is Deborah Wright, and I'm an Executive Director here at the Health Quality Council. QI Power Hour is a free monthly WebEx offering hosted by the Saskatchewan Health Quality Council and provides an opportunity for colleagues across healthcare as well as other industries to hear from local and national improvement experts on a variety of quality improvement related topics. Just a reminder that following today's session, a recording of the event will be posted to our HQC website for you to share out with colleagues who are unable to join us in person today. We also invite you to check out recordings and presentations of past sessions on demand at the address listed on your screen. While you're on our Health Quality Council website, we also invite you to sign up for our distribution list to ensure that you receive regular invites to all of our upcoming QI Power Hour sessions. And over the last number of months, we've been delighted to see how QI Power Hour has continued to spread throughout our province within our provincial healthcare systems, as well as those in other organizations within Saskatchewan who have an interest in quality improvement. We've also begun to see spread to other organizations within Canada and even abroad. Again, welcome to QI Power Hour. I'll now pass it over to Chelsea Schwartz, Provincial Improvement Consultant here at Health Quality Council, to cover a few of the interactive functions involved in today's webinar.
Good morning, everyone. Thanks, Deb. So I just want to remind everyone of the different ways that they can contribute to today's session. The first feature I want to highlight is the annotation function. You can access this function by clicking on the pen icon on the top left hand of your screen and then selecting the arrow icon. So I'm going to give everyone an opportunity to test that, and we'd like to know who is joining us on the call today. So by clicking on the annotation function, show us on the map where you're joining us from. Thanks, Pam. Thanks, Doug, Glenda, Ali. Perfect. So lots of homegrown participation today. So thanks, everyone who is joining us from the province. That's awesome. So the next function that I just want to highlight is the chat function. So this will be important because this is how you have an opportunity to interact with our speaker today. So we invite you to share your questions, your comments, and your ideas as they are spurred for you throughout the presentation. You'll find the chat function on the right-hand side of the screen, and you can access this function by clicking on the message bubble. And we'll have some time dedicated to Q&A at the end of today's presentation. We encourage you to send your questions to all participants so we can all join in the conversation. If you're experiencing any technical difficulties this morning, please direct message the tech support HQC listed in the panelist list there. And we have Lorianne joining us here, and she'll be happy to help you resolve your issues. So let's practice using the chat function by sharing the organization you're joining us from today. So encourage everyone to just pop into the chat. Saskatchewan Health Authority, Ministry of Health, Alberta Health Services, excellent. Oh, some people, we've just recently merged to one health authority, so whereas we used to have 13 distinct health authorities, now everyone's just going to say the Saskatchewan Health Authority, so it doesn't quite give us the same sense of the spread. So welcome, everyone. Thanks for practicing out using this function, and I'll pass it back over to Deb.
Wonderful. So finally, we also would like to invite you to log into your Twitter account if you have one and tweet out during the session to share your learnings. You can use the hashtag QI Power Hour and the handle HQCSask. So now I'd like to take a moment to welcome and introduce our speaker for today, Merit Osman. Merit has been part of Health Quality Council since 2012. He's currently part of the Rural Dementia Action Research Team, or RADAR for short, working on multiple projects investigating healthcare utilization, comparisons, and trajectories for people living with dementia. His responsibilities also include developing costing methodologies using Saskatchewan administrative databases. Merit is also involved in other research projects with health system partners, including the Ministry of Health, the University of Saskatchewan, and clinicians, on topics including mental health and addictions, the burden of illness, and treatment of evaluation. Merit received his Bachelor of Arts degree in Economics from the Bilkent University, Turkey, and a Master's of Arts degree in Economics with specialization in Health Economics from the University of Saskatchewan. So with that, I invite Merit to walk us through his work.
Thank you so much, Deborah, for the lovely introduction. And hello, everyone. First of all, thank you so much for joining to this month's QI Power Hour. I'm delighted to be here, and I hope this will be a beneficial and informative session. Today, I'll be presenting a relatively small portion of a big-scale work that we are focusing on here at HQC with our multiple partners. My presentation will take around 30 minutes, and we will open the floor for questions when I'm done. But just a clarification, that small reminder maybe that please keep the hardest questions to the person next to you, and filter me the easiest ones. So with that important clarification, I think we can start. First of all, I would like to clarify the term I'll be using throughout the presentation, high-cost patients. In any jurisdiction, majority of the residents are likely to use some healthcare services, and this can be through regular physician visits, annual checkups, receiving prescription medications, going to emergency departments, and or having a surgery. By receiving these and other types of services, virtually every resident accounts for some healthcare costs. By using the term high-cost patients, we'll be referring to a patient group with high costs relative to a predetermined threshold. Now, it's a technical term and also used in the literature and with no judgments implied. By the end of this session, you guys will understand how high-cost patients are identified from the administrative databases, recognize the characteristics of high-cost patients, and recognize the healthcare patterns that may lead patients to accumulate high costs. Well, as the title entails, and you will see throughout the presentation, the discussion will flow around the costs. However, as seen in this slide, we see costs as a part of a bigger conversation tying back to value of healthcare delivery. We believe the questions we ask here are how we can maximize the value given our budget constraints and cost structures, or how we can maintain the highest value of care with minimal resources. From the economics point of view, this can be seen as a maximization or a minimization problem, and in theory, there should be optimal answers to these questions. But in light of this framework, an analysis focusing on high patients help us to elaborate and brainstorm whether or not these patients are receiving the care they need, and is it to the highest value, and also are there any gaps in the healthcare delivery that we can see through these analyses, and also are there any opportunities for improvement and better serve this population. In a limited resource system like healthcare, analysis of this nature focusing on high-cost patients can be very informative. Now, let's look at our agenda for today. First, we are going to start with the overview of high-cost patients and healthcare costs. And then we will briefly talk about the administrative databases and how we identified high-cost patients from these databases. And once we define our cohorts, we will take a look of characteristics of high-cost patients in Saskatchewan using our data from 2015 and 16 fiscal year, and their patterns of healthcare use we are going to explore. And I'm going to list some of the relevant provincial initiatives that are focusing on this issue and also related, and then we are going to conclude, and then you guys will say, oof, it's over finally. And here, so healthcare costs are skewed, and they're concentrated within a small number of patients. And this evidence comes from multiple Canadian provinces, as well as other countries. And in a minute, I will show you that Saskatchewan is not an exception. And high-cost patients are a heterogeneous group consisting of people from all age groups with complex needs, and these needs can be directly related to health and or social issues. And targeted interventions to provide better care for these individuals are implemented in many healthcare systems. And here in Saskatchewan, we have a program called Connecting to Care, which is an ongoing program in Saskatoon and Regina area. Before we delve into our detailed analysis, here I would like to give you guys a brief introduction to the relationship between costs and different healthcare services. The values I will show you, as I mentioned in the slide, are driven from budgets and volume. So if you visit your physician, a regular visit can range from $35 to $75, and these are taken from the fee schedules. This is a cost for a consultation with a physician. So of course, the cost of your visit might change and depend on the intensity of the services you receive, but more or less, most of the time, this is the case. And on average, a cost of a prescription drug is around $50. However, when we receive care in more organized settings, like emergency department, the costs tend to be higher. For instance, we estimate the cost of an emergency department visit to be around $370, and this is per visit. And hospitals are, not surprisingly, have the highest cost. Majority of the time, our estimates show that the costs are somewhere between $800 to $1,600 per day in hospital settings. And last but not least, again, our estimates indicate that the cost of long-term care stays being around $230 per day. Now, I think this slide provides the first clue around which services the patients with high costs will be utilizing more compared to the others. And here's a small introduction to administrative databases. And this is one of my favorite slides, as majority of my work involves working with the administrative databases. But in reality, I just went wild with the animation, and I just wanted to show off to you guys. So let's look into a scenario how healthcare use and these databases interact with each other. So here we have Mrs. B, who is a 72-year-old Saskatchewan resident living alone in the community. And she has multiple chronic conditions, including COPD, diabetes, and hypertension. And on Monday, she didn't feel great, and she went to see her family doctor. Upon a consultation, her doctor prescribed some medication to her to control her hypertension. And here we see her going to the pharmacy and getting her prescription. However, even after taking the medication, she did not feel better and needed to visit the emergency department. And after the physician's initial assessment, she has been admitted to the hospital. And she has spent 3 days in the hospital, and through conversations between her, family members, and her doctors, it has been decided that the best care would be for her to be in a long-term care facility. So numerous interactions like this are happening every day in healthcare. And each interaction is captured and stored in what is called administrative databases. And here's a list of some of these databases that we utilize, and this is not the whole list. But what is great about them is that they're linkable via encrypted health card numbers of patients. And as researchers, we don't know who the patients are, but we can see the care that they receive across the spectrum of healthcare. So here's the method, and we can go into kind of juicier details of how we have identified the high-cost patients. After learning about the cost structures and administrative databases, here's how we define high-cost patients. And here's an appropriately drawn map of Saskatchewan. And in 2015-16 fiscal year, we had around 1.2 million residents. And by using the databases, and specific to these analyses, we have utilized only these 5 databases that I'm showing here. We have calculated the accumulated cost for each patient using these databases. And once we find individual costs for each patient in each database, then we sum them up and find the total cost in 2015 and 16 fiscal year. Well, it's worthwhile to mention at this point some of the limitations is that the databases such as diagnostic imaging mainly contains CT scans and MRIs, and laboratory data containing laboratory work and home care data were not available at the time, so we didn't utilize them. But once we assign the individual costs using these databases to each Saskatchewan resident, things get a little bit easier. So what we do, and generally what is done, is that you rank these patients in a descending order by their cost. And once you do that, now you can, through using different methods, you can define your threshold and how are you going to define your high-cost patients. So in the literature, many thresholds has been used, looking at top 1% or 5% or 10% patients with the highest cost. And just to note that these are arbitrary thresholds. And aside from these, more sophisticated methods are also being utilized, such as looking at the distribution of the cost and looking into deviations from the mean, etc. But for today's exercise, we have chosen top 5% of patients as our high-cost patients. In other words, these patients have higher costs than the remaining 95% of the patients in the province. And in dollar terms, these patients have a yearly accumulated cost that are greater than $10,700. Let's look at this graph to analyze the overall spending of different cost groups in the province. Now, on the left-hand side, we have our 1.2 million residents ordered by their cost, and as you can see, the top 5% are color-coded, and the rest is also color-coded. On the right-hand side, we have the total cost of those 5 service areas. These costs are underestimated, as I mentioned that we can only quantify, we only use 5 databases. And we were able to quantify $3.4 billion of our budget, which is around $5.6 billion. So please keep in mind that the dollar values that I'm going to show you are underestimated. Our findings indicate that top 5% of patients with the highest cost in the province consumed around 66% of healthcare dollars. And that will be our cohort of interest during the presentation, and I will call this group, again, as I mentioned, high-cost patients. Then we expand our scope to the top 10%. I just wanted to show that because it's used in the literature quite often, that their consumption of healthcare costs increases to 78%. And while the rest of the province, that 90%, big chunk, accounted for 21% of the cost. Overall, we found that top 5% of patients accounted for twice the healthcare dollars compared to the rest of the province. So that is the $2.3 billion versus the $1.1 billion as shown on the right-hand side. And then we were curious about the components of the cost for the top 5% of patients and really how it compares with the rest of the population. So for our top 5% patients, we had little over than 59,000 patients in our cohort. And as you can see, the majority of their costs are coming from hospitals, and long-term care is the other big component of their costs. And as you can see, drug and prescription has a relatively smaller piece in the pie. Now, when you look at the rest of the population, now we almost see the things opposite. We see the physician and drug utilizations having larger pieces in the cost pie, and hospital costs are close to 30%, but significantly lower than the top 5%, which is around 50%. And long-term care-related costs diminish significantly for the rest of the province in comparison. And for both groups, emergency department-related costs were relatively small, 1% and 5% respectively for top 5 and rest of the population, respectively. And when we look at the quick comparison, and this is a rough comparison really, when we look at the average cost of patients within each group, we see a significant difference between the costs. And we do believe that this gap may shrink with the inclusion of the cost of other services like imaging, laboratory, and home care. But even with those inclusions, we believe that the average cost will still be significantly higher for the top 5%. Well, let's look at who these individuals are. And from the literature, we know that they're older, they have lower household income, they have multiple chronic conditions, and they tend to report poorer self-perceived general and mental health in health surveys. And here's what our data is telling us. So the age distribution of top 5% is on the left, and the rest of the population is on the right-hand side. And as we can see, we have a higher representation of individuals with ages 65 and older in the top 5% cohort compared to the general population. However, it's not just the seniors population that we see within our high-cost patients, and there are also representation from all age groups. And looking at simple statistics, we see that the average age for top 5% is significantly higher than the rest of the population, 61 years compared to 36 or 37. And finally, there's a high representation of females in the top 5% compared to the rest of the population. We do not have individual level information related to income, and what I'm showing you here is a neighborhood-based measure that we utilize using Statistics Canada's methodology. However, even this is a neighborhood-based measure, our findings are in line with the literature that we see high representation of people coming from lower income quintile neighborhoods within the high-cost patients. And last but not least, there we go. We have looked to an index named the Charlson Index, which is used in the literature to measure the burden of diseases. In a nutshell, this index looks into availability of 19 different conditions for each individual and weighs them based on their impact on mortality. And these weights are then summed at the patient level to come up with a single score for each individual. And higher the score, higher the burden of diseases. And looking at our findings, we see higher burden of diseases on high-cost patients compared to the rest of the population. And the index includes many chronic conditions that, more or less, it can also be seen as a proxy for burden of chronic diseases as well. After looking into cost and patient characteristics, we want to take a deeper dive into the healthcare utilization of high-cost patients and try to identify whether there are any emerging patterns that we see in our data. In addition to the patterns, we want to test the myth of, well, you're looking at a patient group in a really high-cost setting, and there's a very good chance that these costs are likely to be appropriate, and there's not much as a system we can do about it. So let's see what we have identified. Within our high-cost patients, first of all, we see some newborns with serious perinatal conditions or extreme low birth weights, which causes them to be cared in the hospitals and may receive care in ICUs with additional treatments that make their costs high. Then we see people experiencing serious acute events such as strokes, accidents, and coma, and which may require ED visits, hospital admissions, surgeries, and treatments, and follow-up treatments, which again make their costs high. And there are patients who have been diagnosed with major cancers requiring intensive care, such as surgeries, radio chemotherapy, specialized medication, and maybe follow-up treatment in the community, again, which accumulates high costs for those patients. The patterns or scenarios that I have showed so far are more along the lines of appropriate or maybe unavoidable costs, but however, we have identified others such as these. For instance, by using our hospital data from 2013 and 14 fiscal year, we have identified patients experiencing potentially avoidable adverse events in the hospitals, such as sepsis, infections, or patient harm, leading to prolonged hospital stays and or additional treatments accumulating to patients' healthcare costs. Then we see patients with multiple emergency department visits and hospital admissions, and mainly due to insufficient management of chronic conditions and mental health and addiction issues. And these generally tie back to the unavailability of services in the communities. And within this group of patients, in addition to direct health needs, we see social needs such as social determinants of health, income, nutrition, housing play a stronger role. And we also see high numbers of alternate level of care days in hospitals due to patients waiting placement for long-term care admissions or insufficient resources, again, in the community that delays their discharge. And what alternate level of care days is defined by our good friends, Canadian Institute for Health Information, CIHI for short, is when a patient is occupying a bed in a facility, and hospitals in our case, and does not require the intensity of resources provided in their care setting. Overall, occupying a bed in hospitals is costly to the system and adds to the cost of these patients as well. And actually for ALC, short for alternate level of care, this is only one side of the story. And the other side is that its overall negative impact on flow of patients into the acute care system and on wait times in emergency departments, which I will not get into as it's a very deep topic, and probably we can discuss it in 75 presentations going forward, so I'm not going to go into details there. And additional patterns, one other pattern that we have identified is potentially avoidable emergency departments or hospital admissions from residents of long-term care centers. Well, 20 to 45% of these hospitalizations are stated as avoidable or unnecessary in the literature, and my quick analysis revealed that 80% of such hospitalizations happened during 15-16 fiscal year. They are listed and not scheduled. So in our data, pointing to the potential improvements in this area. And the final pattern that we have seen within high-cost patients was palliative care, mainly happening in the hospitals, making the accumulated costs high. And this might trigger discussions for improvement and opportunities for end-of-life care in the province and also maybe in Canada overall. Here I will show you another pattern that got my attention, which is identified in an amazing research paper by our colleagues from the Institute of Clinical Evaluative Sciences in Ontario. And they have looked at their high-cost patients living in the community and identified their healthcare utilizations from patients' perspective. And by linking multiple administrative databases, they have created patient episodes summarizing their interactions with the system. And their analysis revealed that 35% of the time, patients' episodes or first contacts with the healthcare system started with an acute planned surgical event. Well, I think this provides an evidence-based segue to the bigger discussion of potentially low-value or unnecessary care happening in the Canadian system. I would also like to mention the Choosing Wisely Canada efforts, here addressing this issue with lots of clinical direction and educational materials, both for physicians and patients. And after the patterns, we were curious about the reasons of healthcare utilization of high-cost patients. And for this purpose, we have utilized a software that is provided to us and many others by CIHI, namely CIHI Grouper. And I would like to thank them here, take this opportunity to thank them because of this awesome product here. We love it, just to let you guys know. And what the Grouper does, it analyzes individuals' previous healthcare utilizations, and for this purpose, we have provided 2 years of data of high-cost patients to the Grouper, and then it assigns each individual to mutually exclusive health profile groups based on the main condition driving his or her healthcare need. So it's important to mention that patients may have some other conditions as well, aside from the group that they have been assigned to. And here are some of the health profile groups that the high-cost patients are assigned to. And these are not all the groups that are available in the Grouper, but I just included the most costly ones, and they are ranked in a descending order of cost from left to right. And as you can see, some of the groups are color-coded, and they are color-coded green if they are significantly contributing to the hospital attendant level care of days, and coded blue if they are related to mental health-related issues. So it wasn't hard for me to code blue there. The group was obvious. And mental health group has, as you can see, has both colors. And while the first one, reducing alternate level of care days, is a provincial priority, the second one is an area where we are focusing on our energy in here at HQC, and also is a group that I will use as an example going forward. So these are the reasons why they were color-coded. And within this analysis, we can see that chronic, acute, and mental health-related issues are the top 3 causes driving the healthcare needs of this patient group. While they're big groups that may contain many clinically different conditions, you may say, and what is great with the software is that we can drill down to specific conditions to truly understand the specific healthcare needs of this population, along with identifying quality improvement opportunities and maybe the gaps within the system. And however, this is great, but I will keep myself not going into clinical details, as I'm very vaguely acute with clinical knowledge that I can be very dangerous here. So I'm just going to continue with the data instead. So we looked at the age distributions within each groups, and again, I'm going to talk about the major mental health here. Is that, as you can see, it has relatively high average in terms of age. However, one thing to keep in mind is that the standard deviation is big. So saying that the major mental health actually impacts a higher group of patients. And looking at the hospital admissions, and these are just the average numbers within that fiscal year, 15-16, we see that relatively people with mental health group in the mental health group have relatively lower hospitalizations compared to the other conditions such as the chronic, acute, and palliative care. However, what we find was interesting is that once the people in the major mental health group goes into the hospitals, well, they tend to stay longer, and their alternate care level days are actually one of the highest as well. And talking this with clinical experts is that we know that the alternate level of care days are also underestimated here. And when they see this data, they say that that value is way higher than what's reported here. And what was interesting is that when we look at the costs, is that people with mental health, people grouped under mental health, have the highest average cost within all these groups. So that's something we find intriguing and interesting. So far, all the analysis that I have shown you, except the last one with the Kai-Hai group where we used 2 years of data, included single year of data. And when we talk about high-cost patients, well, it might be beneficial to expand our scope to multiple years of analysis to gain more insights about these patterns. And after all, patients may have a bad year and require intensive care until their health episode or crisis is resolved. So through multiple years, we may see some patients in the system that never cross the high cost threshold. As you can see, I highlighted the high cost threshold. This can be anything, for our case, top 5 or top 10%. However, again, we see some patients that never pass that threshold throughout the years that we look into. And we may also see some patients having their costs higher than the threshold only 1 year. And we may see some patients being in the high cost group during multiple years. And on the other hand, we may see some patients having high costs that are higher than the threshold within all the years of study. So we want to test this and explore what do we see here in Saskatchewan. For this purpose, we have identified high-cost patients in the exact same way that I have described earlier, however, this time using data from 2009 and 10. Then we excluded patients who died or left the province throughout the study period of 4 years. And we are aware of the bias that this brings to our analysis. And our study cohort included a little over than 34,000 patients, and we have identified the high-cost threshold as top 5% in the identification year, and then we relaxed that assumption. Going forward, we said that, well, you can be in the top 10% in the following years. And when we follow this cohort of patients throughout these years, we've seen that 29% of patients were high cost only in the identification year, and never high cost again. 41% of patients being in the high cost category 2 or 3 years out of the 4 years of study, and the remaining 30% of the patients were in the high cost category during all these 4 consecutive years. So we find that group to be a separate project by itself to understand and deeper dive. And we were just quickly curious about what were the main drivers of healthcare use, and through Kai-Hai Grouper, we have identified chronic, acute, and mental health-related issues as main drivers. And as you can see, the average age of this group is relatively lower, mainly due to the exclusion of disease residents from the cohort. And that number over there is 58.9 years of age. Well, in summary, high-cost patients consume a higher proportion of healthcare dollars, as we have seen together. And while some of the associated costs may be appropriate or may be unavoidable, but some may be avoidable through better care. And maybe the high cost that we see in the system can be an indication of poor quality. And care may be or might be appropriate, but the location of care might not. And community-based care provides good opportunities for lower cost and higher quality care as well. And here are some relevant provincial initiatives. And as I mentioned in the beginning, in Saskatchewan and Regina areas, we have a program called Connecting to Care, or formerly known as Hotspotting, focusing on case management for patients with chronic conditions and/or mental health and addictions. And patients are enrolled into the programs based on their frequent utilization of emergency departments or hospitals or overall high cost. And course, we have to mention our one of the biggest initiatives in the province, ED Waste and Patient Flow, and which is currently evolved into connected care strategy with 3 main components: better hospital care, connected teams in hospitals, and better transitions between acute and community care, high-quality care transitions, and better community care through connected care teams in the community. So basically, the overall idea is to reduce the alternate level care days and change the location of the care, if you will, from acute care system to the primary care or the community. And we also have an appropriateness team focusing on under, over, and misuse of some services, as well as understanding the variations in care and implementation of clinical guidelines. And currently, the team is focusing on implementation of CT lumbar spine checklist along with preoperative testing guidelines. And again, this is around the lines of evaluating the care, whether it's appropriate or not. And moreover, we have various initiatives focusing on providing better care for our seniors in the community. And here are some of the programs that I have listed here. And last but not least, we are working on, as a province, on the implementation of Mental Health and Addictions Action Plan, along with a framework to ensure that these services are provided on patients, based on patients' needs. And to conclude, what we would say is that one size doesn't fit all, and there are different reasons, really, why patients may pass a certain cost threshold. And interventions must be designed based on a thorough understanding of targeted population's specific needs. And when we discuss cost of healthcare, I think we believe it's important to keep in mind the framework that I have mentioned, and where the cost is tied with the value, and that they really go hand in hand. And whether the location, type, or appropriateness of services are allowing for the best possible value should be a defining criteria for delivery of healthcare. And the databases that we have developed here at HQC and further analysis identifying high-cost utilization could be used to better inform decision-making and when, where, and how we should intervene, if we have to, and through development of quality improvement programs and to inform healthcare policy. And with that, that concludes my presentation.
Great. Thank you, Merit, for your presentation. And I'm always amazed at the story that data can tell us. When we start to listen to the patterns that began to emerge as you looked at the data, I find it fascinating to hear that story. So we're now moving into our Q&A section of today's QI Power Hour. And so what we've done is we've been monitoring the chat as we've gone through Merit's presentation today. And we have had some questions come up. So I'm going to review one of the first questions that we've seen come through, and I hope it's one of those easy ones, Merit.
So I totally agreed on that.
So we have a question coming from Richard Edwards with the University of Toronto, and his question to you is, how fair is it to compare a 5% slice to a 95% slice? So, for example, the average of the 95% will be much lower because it may include, and for however many, a number of people who would have zero health care expenses over the year. So is the difference being exaggerated?
No, that's a great question. And I think, again, through my experience and looking at the literature, I think these comparisons are not in the name of fairness per se, but actually looking at the distribution of healthcare costs, and then basically trying to understand the reasons why these costs are concentrated within a small group of patients. And I totally agree that 95%, there are people who never had a contact with the healthcare system, and it may not be fair. But even so, if we compare the ones that utilize the system, the cost will be higher. And because this is, again, a small, relatively small number of group that we identify through high-cost patients, that the denominator will be always low, and their costs will be higher, that their average will come always higher than the rest. And again, aside from the fairness, I think the real lesson here, or the real value here, is that looking at these patients and try to identify whether their needs are really being met in this current system, and is there anything happening that we can serve better to these patients. For instance, one of the things that we have been seeing is the repetitive admissions to the hospitals or the emergency departments, and then that's, through these analysis it may trigger and say that, well, maybe there's something not met here, and then that's why these patients are coming to our healthcare system more and more, and again. So those are a couple questions. Again, some of these admissions and emergency departments might be appropriate, but this is the first step to look into that. But I agree with the question that it may not be fair in the long term.
Wonderful. Thanks, Merit. We also have a question that I believe is coming from Max Turgeon. So he wants to know, so of the high-cost users that are in the top 5%, they're there because of a combination of systematic elements, so underlying medical conditions, as well as random, and he says sort of bad luck, variation. So how can we account for this in the data analysis so that we don't end up interpreting noise?
Well, I totally agree, and when Max is here, we can go into deeper discussions about this as well, is that I think that's correct. I mean, there's a random variation. So one way to look into this is that the analysis that I have mentioned as looking at these patients throughout in a longitudinal sense, and then try to understand maybe there were some random variation that these patients were there, and then they're going to go back to their original regression to the mean. But basically, maybe that noise can be minimized. I don't know whether it will be fully gone there, but can be minimized if you look at these analysis over time. And I hope I understand and answer the question rightly. But again, Max, when you're here, we can go into more detail as well.
Wonderful. So I'm going to encourage, we're just looking at chat. If folks have any additional questions, we do have some time with Merit. He's also happy to receive questions following today's session as well. If people have questions, you certainly can reach out to him on the Health Quality Council website. His email address is listed there. But we'd like to certainly entertain any more questions or comments that folks may have. So we do have another question. I'm not sure who that one's from. Oh, from Ali Bell. Okay, so we have a question. No, maybe Ali. Is it from Ali? Oh, sorry, we're just screening through here. To what extent do you think high hospital costs are driven by patients with few visits but expensive care needs versus patients with multiple inpatient stays?
That's a great question, Ali. That was something that I was about to do. It's on my desk, actually. I'm just doing those analysis. I don't have exact numbers, but I have to say, well, I don't want to guess which one is higher, but that is the analysis that I'm currently doing. So you're ahead of me. And again, that's a great question, because what we see is that sometimes we see patients staying in the hospitals months, or close to some. There are some extreme cases that number can be extended to years, which makes the cost higher. But at the same time, we see again patients coming through hospital hospital admissions and emergency departments over and over, and that's a group that we are actually looking deeper into the frequent visits to hospitals. And I don't have an answer. I'm sorry, Ali, but that's something that I'm doing these days.
Great, thanks, Merit. And Ali's question made me think a little bit of a question I was going to ask, which is, as you started to go into the data and look at some of the patterns, see some of the stories that are emerging, I guess what other questions are starting to surface for you? So you said there's kind of one on the side of the desk that you're going to start diving into. Do you have other questions that have started to surface that you've become curious about that you would want to dive in deeper?
Well, we have a couple other projects going on the other sides as well, and there's a specific one that one of my colleagues, Maureen Anderson, is focusing on people with mental health and addiction issues. And while what they are doing is they are looking at one of the questions is that in our administrative databases we are always low in terms of data related to the social side of things. And what they are doing is that they brought some data from the observatory around dental care and also housing, that they are looking into the impact of social issues in terms of the costs and also the impact on their health. So that's one thing that's happening, which we're curious about. And I think our next step is, which again we are overall curious about, is the predictive side of things. And it's nothing new, and it has been done in other jurisdictions as well. But the question is always that are there any patterns, are there any clinical cases, are there any things or signals that we can pick up before these patients pass that cost threshold? So it's the predictive side of things. Maybe we will be moving towards, but again, this is a big piece that multiple things happening, and those I think identify as the two things that we'll be working on.
Wonderful. Thanks for sharing. So we've had another question come in, and this one is, shares that obviously the admin data will show people's interactions with services, but is there any way to estimate people who don't show up but should? So these are people in lower income, poverty, rural, where the literature suggests that they aren't able to access services even when they should. Good question. Good question.
No, that's a great question. That's something we are working close with our with really experts, and for me, I'm coming mostly from the data side, and we know that there's unmet needs in the communities or in the province, and at the same time, that is, and also the issue of access, especially in the rural side of Saskatchewan, is another issue. And through these analysis, again, these patients may look like from the cost side is that, well, maybe everything is going great, but actually it's not. So that's one of the harder pieces that we're trying to solve. And on that one, we rely on our experts and try to focus on specific analysis regarding to access. For instance, well, it's vaguely related to high-cost users, but with the dementia research that we are doing, we are specifically looking at whether there are any differences between the healthcare utilization of patients who are living in rural areas versus urban centers. So that's something that we are exploring with our experts, and hopefully the scope will increase. But that's a great limitation, and it's harder to tease out with the databases, I think.
For sure. No, that's great. Now, we have another question from Patricia DeSeaman. I hope I've pronounced your name right. How would you determine the success of interventions? Is it that a patient drops below the threshold for longer than they are above when you're looking at the 5%?
No, hi, Patricia. That's, the success of an intervention is a big, I would say, box that we can, but maybe with multiple things in there. For instance, the success would be through these type of treatments or the program, for instance, that we have in Connecting to Care. And when you look at the patients who are maybe enrolled in these programs, well, cost might not determine the success. And if we look at these patients and if we say that, well, maybe they had this healthcare needs and then it got never met in the healthcare system, and maybe when we pick these patients up through these interventions, maybe their costs are going to go up because they're going to receive the right care that they didn't receive throughout all those years. So, I mean, cost would be well. On the other side, we can look at the patients who have been accumulated high cost, and then maybe through these interventions we realize that, well, maybe we can provide better care in the community, happen to be in a cheaper way. So, I mean, I don't know whether just looking at the thresholds and defining the success would be something, but I don't think it has to go with other outcomes that actually makes it fair in terms of the evaluate the success of these programs. And she knows from the first hand that I know the root of this question too. Yeah, like, I mean, that should be additional metrics that we should be looking into, and the cost might be unfair. And yeah, and we can chat more, Patricia, whenever you have time.
Wonderful. I'm just going to take a pause to let folks, if they have a question on the top of mind that they'd like to bring forward, to type it into chat, or if you have any follow-up questions based on some of the responses that Merit has offered to the questions that have come forward. Now is your time. If not, you can, as mentioned, also reach out to Merit following this session. But I don't want to rush your questions if you're in the process of typing.
So we'll give a few more minutes to wrap up those questions, but in the interim, as questions are coming forward, I just do want to invite you all to join us for our next month's QI Power Hour. So we'll be back on March 16th with Brandon Bennett. He's the Principal Advisor with Improvement Science Consulting. Brandon will be speaking about his work in leading intersectoral collaboration and quality improvement initiatives. He will highlight some of the innovative practices he has been part of that seek to improve health and well-being by bringing together stakeholders from healthcare, education, judicial, and social welfare systems. So kind of the topic of thinking upstream, touching on the social determinants of health and how those are key drivers to whether or not people do end up in the healthcare system. And just as a reminder, we do welcome you to provide your feedback on today's session. So you'll notice that when you close out of WebEx, a survey will launch. And we'd appreciate your feedback, and we will look forward to connecting with you again next month.
Okay. Thanks.
I will keep you posted on that one, Patricia.
Okay.
I was just reading your comments.
Yeah, thanks, Patricia. So interest has been shared in predictive data, so there'll be some follow-up conversations in that regard. Wonderful. So, Merit, I don't know if the deal held. I think those hard questions weren't offered to the persons next to them, but rather brought forward to you, and thought you did a great job in responding, and great questions that were brought forward. So thanks to everyone who participated today. And with that, I'm not seeing any further questions coming forward, so we will call it a day, and hope everyone has a good one going forward, and look forward to seeing you all back on March 16th.
Thank you.